because people, if I can say it this way, many people that don't move for a living are somewhat divorced from sensation, right? That's basically how a lot of us get through life. Right? We feel stuff, we ignore it. So we have often trained ourselves to pay very little attention to things that are potentially problematic.
So I am honored to again have on Dr. Cobb, who's my hero. I hope you know that. You're my hero. Because don't shake
Very
your head.
sad.
Well, because I felt like a lost little puppy dog for a long time. A, in my own body. B, I was like, I knew I was interested in biomechanics and the human body, but looking back, I felt a bit lost. And now my body is working. I feel so excited about what I'm learning. And I'm actually having results with my clients, which I think is the most important thing to highlight.
Absolutely.
So thank you for Z Health.
I'm happy to hear all of that.
I know it hasn't been an easy journey for you bringing Z Health to the masses. So I just want to say thanks for your persistence.
Thank you. Yeah, it's I was thinking about this intensely the other day. It's been an interesting, difficult ride. I mean, we're 20 years this year, and it's pretty fascinating to watch the growth kind of around the world of this concept, this idea that, hey, we should know more about what's happening with the nervous system and blend that with what we know about biomechanics. So it's been very interesting to be kind of a participant and witness as I think things have evolved, but it certainly has been challenging, just like every field. You have something kind of new, kind of different, and there will be periods of resistance. But ultimately, it either works or doesn't, right? There's some proof in the concept. And so I'm happy to see that at least happening.
Yeah, definitely is working. And one of the things I wanted to bring you on the show today to talk about is headaches, because so many people struggle with that. Before we get into that, though, I do have a personal question to ask you, because I teach online yoga classes and I teach groups in person as well. And I have this desire to blend the brain drills that you guys have taught me that have worked so incredibly well with these groups, but you have kind of drilled into us, and I've seen it myself that not every drill is going to work for every person. So I'm faced with testing out things, and sometimes people come up to me and be like, oh yeah, your class made me feel like I was going to throw up, and I'm like, oh no, that was all the easy drills.
Right. Yeah.
Any tips for us people who are teaching groups? And I mean, that's a horrible question to start the interview with, but I was like, I have no clue if what I'm doing is actually hurting people, or should I be pushing them? I don't know.
Yeah. So, this is an interesting topic because it really bumps up against the science of exercise. And this is, I think, something I've been talking about for literally before Z Health. Because as a movement coach, a tennis coach, martial arts instructor, teaching group classes is extremely challenging, because I think all of us know that if we have kind of an average client, right, someone who's relatively in shape, they don't have a tremendously bad medical history, etc., that we can probably do something fairly general with them and they'll have decent results. But everything that we're seeing in medicine, in movement therapy, et cetera, is pushing further and further into this idea of personalization and individualization. In the cancer world, doing a ton of testing, looking at individual gene sequences to try and figure out how, will this person respond to this medication or this medication? And basically what I generally teach in our courses is group classes are basically there as a screening tool. And what I mean by that is I think it's a fantastic thing to offer. You teach online, you teach group classes, you get people moving. I think the key as an instructor is to be very clear with them in the beginning and throughout that if something doesn't make you feel good, there's a reason for that. And we need to find out what that is, because that may be a key that's giving you pain. It's holding you back from progressing in your practice. So I've always directed kind of the people in our courses to think about group training as a screening tool. If there was, if you've got 20 people, 18 are responding relatively well, and they are sharing that in the process, and 2 are like, yeah, that made me want to throw up. Well, then we probably need some more individualized assessment for you so that we can personalize this, because you have some underlying issues. And I think the hardest thing for teachers in general that do a lot of group class work is they are uncomfortable with that. But it's not your fault,
Yeah.
right? And that's what I've seen this over and over in that, like, well, I feel bad that the exercise made you sick. You didn't do that to them. Their nervous system didn't respond well. And again, if you've done some due diligence, you've explained what you're doing, you're explaining to them how to do a little self-assessment, be aware of yourself, be aware of what you're feeling, stop. If you don't feel well, don't continue. If they wind up feeling terrible, again, to some degree, that's on them, as long as you've told them what to look for. I have always encouraged group class teachers to teach basic forms of assessment or self-assessment and have people use them throughout a class. Whether that's just a basic movement reassessment, whether that's a balance reassessment, whether that's a body scan. I'm just going to see how I'm check in. I'm going to see how I'm feeling, and help people kind of self-grade. In the strength training world, this is related a little bit to the idea of autoregulatory training, where you're kind of paying attention to, do I feel like I can push hard today or not? So there are multiple iterations of this in multiple fields. And I think we just have to be very upfront with clients, and be okay with the fact that, hey, if we discover something in this class that you're not responding well to, then you need some individualized attention.
Yeah.
And just, leave it at that. You didn't, if people are in pain, if you didn't run over them with your car, that's not your problem, right? It's not your fault. It's ethically, what we have to do is explain to them maybe what's going on and say, these are some approaches that we could take. So that's my general take on group classes.
That's extremely helpful already. I mean, I think one of the challenges that particularly the style of yoga that I've been teaching groups is that we kind of link all the postures, and I was then linking in all the brain drills in there, and people were like, I am not feeling well doing your stuff. And I was like, maybe I'm overdoing it just a bit. So I've definitely pulled back. So I've learned so much through the process. I'm almost grateful I've done it, but I was really curious to hear what you said. And I think, the easiest thing is probably the body scan. I think that's brilliant advice.
Yeah, if you can help people understand that if they're feeling, if they're going through a practice that is designed to make them feel better, more relaxed, and they're 20 minutes in and you just did a posture followed by VOR drills, and their back's locking up or they're feeling a ton of tension in their feet because they can't balance, that's a problem, right? So I think again, as long as it's well explained, because people, if I can say it this way, many people that don't move for a living are somewhat divorced from sensation, right? That's basically how a lot of us get through life, right? We feel stuff, we ignore it. So we have often trained ourselves to pay very little attention to things that are potentially problematic. So without coaching and without being directed to, hey, are you feeling tension here? Many people are unable to even identify that. So, as an example, in some of our advanced classes where we're working on speed development is deeply related to relaxation, even under load. And so when you look into the literature, there's different forms of relaxation training, that have been around for a long time. One of my favorites is autogenic training, which is basically, I want you to pay attention to your right foot. You're going to tense and relax and tense and relax. And it's very interesting, even in a group of professionals, that if I take the group through an autogenic training session, how often people will come up and say, I was carrying so much tension in my right calf, but until you said, pay attention to your calf, I was unaware of it. So,
and that's someone who moves probably for a living.
Yeah.
Can you imagine someone who's sitting in a chair all day?
Right. And so that's where, as I said, I think the clarity that you bring to all the explanations and really telling people what to look for. Because the difference between amateurs and professionals in almost everything is that they have a more clearly refined map of what's important and what's not. So if you're teaching people about movement and teaching people about their body, then you need to be very clear with them on this is important, this is not.
And this is why I'm studying with Z Health, because I'm trying to figure out what's important and what isn't. Because I was going on and on about all the unimportant things for a hell of a long time. And I was like, oopsie.
That is the route we all take, sadly.
Well, no, I mean, I just want to say thanks, basically. And the other thing I wanted to say thanks for was you've got this new membership available on Z Health, which is the BPGP, which is hard to say.
Trust me, even in our team meetings, we're like, you know what, the membership, don't even try.
Yes, the membership. And guys who are listening, basically the reason I wanted to bring Dr. Cobb in is I have a couple of clients that have severe chronic headaches. And as soon as I saw that that was one of the first parts of the membership, I was like, oh my gosh, no brainer. So I got the membership, hours and hours of lectures. And then it was funny because I got to the end with the Q&A and I was like, oh, I still know nothing. Because all the questions you were answering, I was like, wow, I wouldn't have been able to understand this even. So it's a huge, vast topic, guys. So I just want to say, quick side note, forgive me if we're not covering your exact issue, but we are going to try our best to give you guys some practical tools of things that can help based off of some of the information that Dr. Cobb has shared there. And obviously listening to you do the Q&A, you obviously knew so much more and you were just going on about things. I was like, wow, like I have got my work to do. Like there's a,
Well,
but
the membership programs, I have loved them. I think putting them together is incredibly fun and cool because there's so much emerging information, but it's a 5 to 6 hour course as opposed to 5 years of working in a headache clinic. There's a lot of information on headache, and we try to pull out the most important pieces, but then as you start getting deeper into this topic, you have these very rare, unusual presentations that they're certainly harder to find, and in many cases they're harder to address. So
but I mean,
it's a big topic.
Even the foundation that you laid already has helped me move the needle for my clients. In
Good.
ordinarily, I wouldn't have had that opportunity. So it is still great, all the stuff. I guess, wanted to preface the fact that this is a massive topic. So now that everybody knows that, let's definitely touch upon what are some of the big misunderstandings around headache. I know in the membership you were talking about, it's kind of ignored. All of us movement people, we're just like, oh, you got a headache, don't come in today. But actually, there's a lot we can actually do to help people.
Yeah, this is one of my little rants that I always go on about.
Oh, I love a rant.
Different issues. In the movement world, we tend to shy away from, first of all, in the movement world, we shy away from anything from the neck up. Unless it's a specialist who does TMJ work or headaches, etc. We just kind of ignore it and go, it'll go away. And when it goes away, come back and we'll do the cool, important stuff called exercise. But the fact is, when you start to dig into not just headache, but almost any presentation, right? Any pain presentation that people might have, there usually is a rehabilitative process available that in most cases has not been explored because it is extremely unusual for any practitioner to have kind of a full scope vision of what could be done, right? Because most of our traditional training methodologies take us in one direction. And I'm actually going to use a kind of a personal example here. My son is just about to finish his 3rd year of medical school. Prior to going to med school, he spent 2 years in a pediatric clinic, and he spent a full year he spent 2 years in, one was in a neurologic rehab clinic, and the other was in a headache clinic. That's all that they did. And the headache clinic that he previously worked in was very cool because the doctor was a neurologist. All he did was headache, and he was very aware of the fact that his tools were somewhat limited. He had injections available and he had medications available. And he recognized that if those were ineffective, and which they're going to be in many cases, because that's just how things work. He also, within that practice, had a physical therapist, a massage therapist, a chiropractor, a vision therapist, and a vestibular therapist. So it was actually a doctor who said there are many reasons that these headaches may be coming. And from a medical perspective, a lot of what we do is symptom control, not rehabilitation. Because when you want to look at a rehabilitative process, it's probably going to involve more than just meds. And I'm saying that to contrast that with, in one of his most recent rotations was a neurology rotation. And, half the people they were seeing in this neurology rotation were migraine sufferers, etc. And in that particular practice, the only real options they have made available were medications. And actually most of the medications that were being suggested in many cases were probably 5 to 7 years out of date.
And had side effects.
and because of but that was the practice modality that doctor was using. And I'm not here to judge anyone's, I'm not seeing these patients, so I can't judge what they were doing. But talking to my son about it, he had this very interesting, like, compare contrast of, okay, this is kind of a traditional practice. This is more of a forward thinking practice. And again, from the ZL perspective, anytime someone has a condition, whatever that may be, our curiosity is there something that we can do to facilitate that client or that patient or whatever moving beyond this, where it becomes something that they're not managing, but something that they have recovered from. And I think in the movement world, very little attention is given to the idea that you can recover from a headache presentation, depending on what type it is.
Oh my goodness. You know, Dan actually had long COVID and he ended up getting this crazy headache.
Mm-hmm.
And we actually had an online assessment with a neurologist, and he just gave him pain medication. He saw him for 10 minutes, didn't ask him anything about, we're going to talk about the classics in a moment.
Yeah.
And then he took the pain meds, it didn't work. And Dan has a slight lazy eye. And I was like, do you know, maybe we could just try a couple of vision drills. He was really resistant to the whole Z Health thing for a while. I was like, could I please just try and do something for your eye? In the end, no. But I said, you know, why don't we try put a patch on your strong eye and see if that'll take care of your headache. Anyway,
Right.
He was like, of course, disagreeing. I'm on a call with work. Suddenly he runs down the stairs, almost breaking the stairs down with like my eye mask that I sleep with on his strong eye. And he was like, my headache's gone. My headache's gone. I was like, and then from then on, he was a convert.
Yes.
But I was just disappointed that the neurologist didn't ask about A, the classics, which we're going to discuss now, or B, even just at least check his eyes. I was really sad about this.
I mean, it's I would say in medicine in general, the days of the generalist have gone away, you know, where the training obviously is different around the world, different medical university approaches, but in general, you know, I think physicians become more and more specialized, and often, you know, anything that they even consider potentially a problem with the eyes goes to the ophthalmologist. Anything related to the sinuses goes to the ENT. If it's a TMJ problem, again, I'm going to refer to oromaxillofacial surgeon or whatever. So it seems that in many cases, the window of the things that they're willing to evaluate and assess, unless there is a true, from their perspective, diagnostic issue, like, hey, did he have a stroke? Did he, etc., that for the most part, it's about management. You have pain, we'll give you some pain meds, hopefully feel better. If you don't, I'll refer you to someone else.
Yeah, it's so sad. And even like I have another client who's really suffering with headaches. And I said to her, oh, have you had your eyes assessed? Yes, I went to the eye doctor. Oh, what did they do? Oh, they just put stuff in my eye to dilate my pupils. And they just asked me about acuity. And I was like, so they didn't check like convergence or divergence. They didn't check tracking. And in the end, we discovered her eyes don't actually like moving to the left. Whenever she does that, her threat goes up. I'm digressing. Let's get to the classics. Because I can just rant about the way things are for a long time. You mentioned in the course about how important it is to kind of assess diet and sleep and water intake. And certain foods can obviously be triggers. Of course, sleep is such a huge thing, but I was fascinated to learn that actually some people could be drinking too much as well as too little water.
Yeah,
that was
absolutely
fascinating for me. I was always told it's dehydration, got to drink loads of water.
Everything's about dehydration. Yeah, this is kind of funny. I won't call it a pet topic, but I find it interesting. When you really look for the research on how much water we're supposed to drink, there isn't any. Like there's no actual hard data. I think most people have heard you need whatever 2 liters a day.
Yeah.
In the US, they would talk about you need 8-ounce glasses per day or something. And some people actually went and looked where did that come from? And it was actually, the idea originated in a Japanese marketing campaign for a water company. So in general, what you'll see, most research scientists now talking about hydration, they're like, if you're thirsty, drink. If you're not thirsty, don't force yourself.
Okay.
Because what can happen with excess water intake is it can create electrolyte imbalances. Now, obviously, I think almost everyone has heard of the idea of water intoxication, that you can actually drink enough water to kill you, because it can make your electrolyte balance so poor that it can induce basically heart issues. So I'm always curious when I'm working with someone with headaches. It's one of the first questions I'll ask them, like, do you drink water? And they'll almost always be like, I probably should be drinking more. And I'm like, no, that's not why I'm asking. I actually want to know, are you forcing yourself to get 2 liters, 3 liters of water down a day? If so, let's back that off a little bit and see if there's any noticeable change in the frequency or intensity of the headaches, because it can play a role.
That is just so fascinating. And I think also kind of gives people permission to just listen to their bodies a little bit more, because we do force things based on the marketing, and usually marketing has got somebody who needs a bit of money behind it.
Yeah, in general.
In general. But it was quite interesting hearing you talk about cheese. I was like, no, don't take away my cheese.
Yeah, I know. Yeah, high tyramine. Well, so again, one of the things that I think we need to make sure people understand is that not all headaches are created equal, right? They're not all the same. And if you have headaches and you're trying to figure out what should I do about it, one of the first things to figure out is, well, what type do I have, right? And there's classification systems, and you can take online tests and all these basic things. But in general, the 2 kind of major primary headaches we're talking about are migraine, and migraine has a lot of different versions, and then tension type headaches. Now, those are kind of classified. There's another version of headaches as well that most people, if they have these, are well aware: cluster headaches or trigeminal cephalgias, which are usually extremely intense, and those usually drive people to the doctor. But then after that, then we have secondary headaches, headaches that are like a tension headache, but they're coming from the upper cervical spine, etc. So whenever we're talking about foods, high tyramine foods like red wine and cheese, and chocolate, and a few other things that people tend to love, those tend to be more closely associated with migraine presentations. Okay. It's just a kind of well-known issue. So in most cases, if people are getting information or directions about the classics, they'll be told, try to avoid those foods. It doesn't always help, doesn't always work, doesn't always matter, because there's a lot of different reasons that you can have a migraine, but it is something that we try to make people aware of.
Yeah, that's really helpful. My cousin always used to get migraines from eating chocolate, and I used to really feel so bad for her. I was like, oh, you poor thing. But it was so funny, how pain works. We've obviously had a chat on the show about pain. Please go and listen to that, everybody. It's very enlightening. But she was like, I don't care. I want this chocolate. I'm going to suffer because I want to eat the chocolate. I found that quite interesting.
Hey,
it's
you're an
weird.
adult.
You can make these decisions. And listen, I'm so glad you touched upon the 2 types, because I actually have made some little sort of distinctions about migraine. And guys, I think this might be quite helpful. And Dr. Cobb, chip in whenever you want, because this is your words that I'm quoting. But migraines tend to be on one side, and they tend to be really instigated through sound sensitivity, right?
That is yeah. So whenever we talk about migraines, usually single-sided, and they can be associated with what's called aura. So prior to the pain setting in, you can have sound hypersensitivity, light sensitivity, tactile sensitivity, etc. There are also migraines without aura. So you don't necessarily have all these prodromal symptoms, but all of a sudden you start getting this unilateral throbbing pain. And then at that point, maybe you become very sound sensitive or photosensitive.
Okay, that's really interesting. Yeah. I think that the pulsating was another really important key factor, which differs to the tension headaches, where they tend to be sort of a pressing, tightening, bilateral distribution.
Yep, that's correct. So you can have tension headaches that throb as well, but usually the first big differentiator is, do you get headaches on one side? Does it happen bilaterally? What's the location? Is it around your eye? Is it across your forehead? Is it your temples, the back of your head? And those kind of give us some basic starting points.
Okay, so I mean, would you approach treating those two different presentations differently? I mean, obviously yes. So I feel annoyed at myself for asking that, but like, if you have like something really obvious migraine, um, obviously, what's the first thing you would kind of do with someone who's presenting?
So um, the only way to actually answer this is to talk about the management process. So if someone's presenting with a migraine, meaning they have a migraine right now, what we'll start with is something to try to reduce the pain, right? I'll talk a little bit about the anatomy and maybe some targeted ideas. Um, sorry, I think I just bumped my desk. If I'm
Don't
vibrating,
worry.
it's because I
Don't
just hit my
worry.
desk. Um, so before we get into that, I want to actually talk about the idea of rehab, right? So if someone has migraines and we're trying to take them through a rehabilitative process, the first thing you actually have to do is start tracking. You have to have a conversation with them and go, look, we need to use an app or a notebook or something. We need to know how many headaches days you're having every month. We need to have an intensity, because the issue with human beings in general is that we may have pain, but depending on how our brains work, we may over exaggerate it. We may forget about it.
Yeah.
So if you don't have records and you don't have reliable data, it's going to be difficult to know if you're making progress. Because when you're trying to deal with headaches of any kind or any pain that is intermittent in nature, if you don't have data, you're guessing. And that is very frustrating for the coach. It's frustrating for the client. So it starts there, actually. And I'm pretty adamant with people, like, don't, I know you can tell me I get a few a month. That's not super helpful. Like, I want to know how many to the day. I want to know what hours of the day, because that may give us information. If it's a female client, where is it in relationship to the menstrual cycle? Because that can actually play a very large role. So if you are going to go through this process with someone, it all starts with data collection. And you have to explain to them, it's going to be a month or two of, we're going to give you stuff to do, but we have to get an idea of where we're starting. So that would be number one. When you then start dealing with migraine, I think it's super helpful to have a little bit of information about anatomy. So there's still a lot of debate on what drives migraines, why we get them, et cetera, but we do have some pretty well-established ideas at this point. So the first thing that we generally have people, well, again, I'm talking to people as coaches now, not as a necessarily a migraine sufferer, because you might not care until we get to the punchline, which is what to do about it. But in general, whenever we look at migraines, we're going to be interested in what's called the trigeminal nerve. All right, the trigeminal nerve it's cranial nerve 5. It's this big, enormous nerve that does all kind of stuff in the face, head and neck, and also around the brain. So in general, when people have head pain, it involves a loop or a connection between the trigeminal nerve and then a couple parts of the brain called the thalamus and the cortex. So this is kind of the main transmission nerve that we're going to be super concerned about anytime someone has migraine. So if you then think about that and go, okay, well, if the trigeminal nerve is maybe a problem, we need to know what it does. The first thing it does is it gives us sensory information from the skin. There's 3 different divisions of that nerve. There's for the forehead, underneath the eyes, and along the jaw. It also provides sensation from areas of the eye, the sinuses, inside the mouth, on the tongue. So there are a lot of different things that this nerve does. It also is in charge of muscle activity for what we call our muscles of mastication, so muscles for chewing. So whenever we bite down, we can feel these muscles pop out here and then up around the temple, temporalis and masseters. The trigeminal nerve is in charge of how hard they contract. So if you then follow that nerve into the brain, it's going to send information to kind of 3 key areas. All right. And this is, I'm going to talk about kind of the stem. It's called the brain stem. So we have the big brain sitting on this little trunk, and that little trunk has 3 different divisions. And the trigeminal nerve sends information to nuclei in each of the divisions. So we have one on top, that's called the mesencephalon or midbrain. We have one in the middle, that's called the pons. And then we have one at the bottom called the medulla. So here's kind of how this works. If we look at the information that's going into the top of the brainstem, the mesencephalon, from the trigeminal nerve, it's getting information about where my jaw is in space. Okay, how's my jaw moving? It's also getting information from my teeth. So when I bite down, how are my teeth hitting? You know, as I'm chewing food, can I chew food without biting through my lip, biting through my tongue? Your brain has to be aware of where your jaw is and how it's moving. And interestingly enough, that area also gets information about eye muscles. So, you know, part of what you were doing with Dan and putting a patch on and making his eyes move differently, you were influencing that part of his brainstem. The next part, that middle part, the pons, is going to be getting the sensory information. So if you stroke your forehead, you rub your eyes, right? You put saline in your nose, right? Any of those things are going to give sensation. Those are going to be processed in that middle arena, as well as we're also going to be sending the signals to make the muscles contract in our jaw out of that middle area. And then we go to the bottom, and this is called the spinal trigeminal nucleus. And this one's really important in migraine and all headaches, because it's this part, this bottom part, that processes threat information. So what we would call nociception from anywhere. And interestingly enough, it is most responsive to nociceptive input coming from the what's called the ophthalmic division of the trigeminal nerve. So basically around the eyes and the forehead. So basically our brain is more sensitive to pain signals, or what could potentially become pain signals, from this area. So whenever we say, all right, how do I use any of that information to deal with a migraine? Well, what would that tell us? Well, it would tell us that doing some exercises that would help us improve our understanding of where our jaw is in space would be potentially helpful. It tells us that maybe we need to have our teeth evaluated, because if I have a low-grade tooth infection, or I'm biting weird and I'm getting some odd contacts, or I've had some prior surgery done and I have I had a root canal and I've got some weird scar tissue buildup that I'm unaware of because it's not hurting. That could all point to, we need to look at the top. I could then also look at your eyes and say, hey, do your eyes move normally? If not, that's again going to all impact on that area of the brainstem. Interestingly enough, that area, that top area of the brainstem, also plays a role in processing sound. So this is one of the reasons that we probably have this hyperactive response when we have a migraine. Then it would also tell me that maybe I could use sensory stimulation to influence that middle part. So what you'll see us using a lot in dealing with headaches is we'll use vibratory tools around the forehead, around near the eyes. We might use different variations of heat and cool around the face. We may combine those together where we're using vibration and hot and cold all at the same time. We can also go through sensory retraining, where we take a Q-tip or a piece of cotton. We have you close your eyes, we stroke here, and we ask you, does that feel the same? And very often what you'll find in people with migraine is that they'll say, oof, no, that side is really sensitive. And so we will start trying to do some type of sensory retraining to make you understand, nope, it's supposed to feel like this. And there's some different ways to do that. And then from there, as we start to kind of work our way further down, we know, as I said, that this area responds a lot to this ophthalmic division. So that's going to tell us that in addition to the jaw work, the tooth work, the sensory work, we're probably going to concentrate a lot of our sensory efforts in this division initially.
Which is the eyebrows and just below the eye socket, just in case people are listening and not seeing you.
Yeah. Because that may actually give us the greatest amount of kind of blockade of signals going into that trigeminal nucleus there. So I know it's a lot of information, but those are kind of different approaches that we would probably start with, in addition to using things to just downregulate threat overall, like breathing, maybe a little bit of eye massage, assuming they don't have glaucoma or some kind of other comorbidity.
So yes, it is a lot of information. And one of the things that I keep saying over and over is that when you start learning about neurology, it's simultaneously extraordinarily frustrating, but
Hmm.
also empowering, because frustrating in the sense that there's so many variables,
Hmm.
but at last we are actually looking at the body holistically. So it's quite cool to hear you talk about things like the trigeminal nerve, how that feeds into the brainstem. And another part that I was hoping you would touch upon, well, two things actually. One is the meninges, because I find that fascinating that your
Yeah.
brain can't actually feel pain.
Hmm.
Well, sorry, the pain is an output. Let me correct myself. But
But
meninges
it's
has the
sensitive.
nociception. Yeah, the
Hmm.
meninges has got all the nociceptors, which I'm just
Hmm.
like mind blowing, I
Yeah.
think. And then also the greater occipital nerve is really interesting. Can you please
Yes.
expand on those two structures?
Sure. So yeah, I'm just trying to figure out the fastest way to explain this. So if people are not familiar with brain anatomy, whenever we take we look at the brain has coverings. Basically, it's almost like a skin on the brain, and it's 3 layers thick. And we generally refer to this as the meninges. Now, almost everyone has heard that the brain itself is insensate, meaning the brain itself doesn't have receptors to feel pain, and that's why they can do open brain surgery on people with a local anesthetic and keep them awake, because they give a local anesthetic and cut away the skull, and they can, be talking to them while they're operating on their brain. That's neat, but that is not the
Very.
whole picture. Because just like our skin is sensitive, the skin of the brain is also sensitive. So the meninges, the covering of the brain, actually has a fairly high density level of what are called nociceptors. These are the types of receptors that are responsive to things that your brain might eventually interpret as pain. And I know that sounds like a long way of talking about it, but it's actually really important that you understand that. Just because a nociceptor is activated does not mean that consciously we will feel pain. It just means that there's something threatening happening in that, and the brain will decide if it's important enough to pay attention to. Now, whenever we look at the meninges themselves, we say, okay, if they are nociceptively active, what nerves are involved in that? Well, guess what? We're back to the trigeminal nerve. It actually supplies a lot of, it receives a lot of nociceptive input from the meninges. If we go to the back of the brain, we then will also potentially pick up some meningeal innervation from the vagus nerve, which is 10, and then also 12, which is the nerve, believe it or not, that innervates the tongue. So we have kind of this, some weird patterning, but generally whenever we're talking about nociception and meninges, we're interested again in the trigeminal nerve. Now, why this is super important, I think, in understanding this if you have migraine, is they've done some experiments, and if they basically inject or irritate the meninges, the response for most people is the development of a migraine. Like the actual pain sensation that will come from that is very much this pulsating quality with often some of the other hypersensitivity issues that people experience. So it is very important to understand kind of these meningeal components. So, the question then becomes, well, what do we do about it? Honestly, pretty much the same stuff. The biggest difference, however, is that if we kind of dig more deeply into the anatomy of the meninges, there is the possibility of influencing behavior of the nerve endings of the meninges by working around the scalp itself. Now, obviously, I have no hair, which makes it super easy to understand, but there are some anatomical pathways or routes by which scalp or skin stimulation of the head may kind of create a little blockade effect for nociception within the meninges. So we have science around that, and I think we have tons of experience. What do people do when they have a headache? A lot of them will actually sit and massage their head or pull their hair if they have it. All of that is a form of kind of self-therapy where they're trying to create some kind of, again, alteration in the amount of meningeal irritation they're experiencing.
Yeah, they're just trying to get a bit of relief. And so this was so fascinating to me because one of the things that, one of the traditional tools that I think have kind of drilled into you is
Mhm.
that, it's all about deep tissue. You got to get in there, you got to break up the fascia. And then I started studying with Zia, and you guys were like, no, you can get quite a lot of stimulation just with like light dermal work. And I was like, wow.
Yeah,
And it's so
yeah.
cool because the way you spoke about it was great. It's like you can actually glide the skin in 8 cardinal directions, like north,
Mhm.
south, east, west, and then obviously the ones in between.
Yep.
And you can actually do that on the skin on your scalp to figure out where there's a blockage. And you can
Mhm.
actually either go into the blockage or away from it, depending on how people retest to
Mhm.
see if that could be a treatment modality. It's just
Right.
fascinating.
Yeah, it's something over the years, I obviously come from the same school, a lot of deep tissue mobilization, manipulation, but over the years in studying neurology, it became very apparent that the brain just needs stimulus and it actually needs it at the right depth and the right spot. And I mean, this is where most of our interaction with the world happens. And while yes, there are underlying tissues, it's silly to ignore the stuff on top. But most of us that come from a manual background, we're taught that the skin's just kind of in the way. Like if we could just get it out of the
Yeah.
way, then we could get to the important stuff.
All
But
that hard tissue that you need to break up.
yeah, but the skin is highly innervated, right? That's why we have it. It's to interact with the world and know what's going on. So if there are deficits in movement or deficits in sensation, yeah, that's definitely something to address because it can make an enormous difference for people. And it does make it very cool because it makes areas of the body that traditionally we couldn't do anything with because we couldn't really do much with the muscles of the skull. It actually makes it possible to think, is this a therapeutic route? Could we do something there? So yeah, I really enjoy that. And then as far as if I find tension in one direction, do I push into it or push away from it? No one knows. I wish I could tell you, you have,
Wow,
and it's
yeah.
funny because there are entire worlds of manual therapy built on going into the resistance and other worlds built on going away from the
But
resistance.
nobody retests these people. That's
And
what
that's the issue,
kills
right?
me.
That's what it comes down to is that this is where personalization is so important. How do you respond?
Yeah,
And most people will respond much better to one version or the other. We just have to make sure we're doing some type of reassessment.
yeah.
So,
Honestly, this is why you're my hero. You have to accept that.
well, all this comes down to is realizing that the human body is smarter than all of us.
Yeah,
You have to approach working with other people with humility. Because if you think that you have the answers, at some point you'll run into someone and you go, I don't have the answers. I'm going to actually, again, small rant here. This happened the other day and I almost lost my mind and shot a blog that probably would have cut my YouTube channel in half. But I had shot a blog on blood pressure, right? And, talking about some different methodologies that are available that have good research behind them using breathing and then isometric hand grips to lower blood pressure, right? Because a lot of people are on medication and it's still not controlled, or they're looking for something they
and
can
there's
do at
side
home.
effects.
Yeah.
Yeah.
And actually, I think that must have been a hot button because it got a lot of traction and a lot of people loved it. But then I had a few people come on and make just comments. Like the one that stuck in my head was, yeah, you can buy these devices on Amazon and decrease your bank account, or you could, eat better, exercise, ride a bike,
No.
get up off the
Come
sofa,
on.
etc. And I just deleted it. But in my, it took me a little time to process it.
Mm,
But then what it really reminded me of the fact is that many people have never worked with people who are truly injured or truly sick.
yeah.
They haven't. They have no frame of reference, right? So yeah, it sounds great, ride a bike, but what if you're working with a vet who has lost both legs in an explosion?
Yeah.
What if you're working with someone who's in stroke recovery and they can't walk more than 10 steps and they
Yeah.
have high blood pressure? So, it's most of us, I think, professionally get into a groove. We're like, hey, this is the kind of person I like
This
to
is the
work with. I'm
thing.
super successful with these people, so I'm going to stick here.
Yeah.
And that's awesome. But if you're going to expand as a professional, you have to take on more challenging things. And then at some point, you're going to run into something and go, yeah, I don't have the answer to this, which means you have to go back and study. And then you may study enough to go, no one has an answer for this.
Yeah, we're still at
So
the
we have
infancy.
to do some testing. We have to experiment.
Yeah.
So anyway, yeah, it's a strange world, and neurology, I love it, like you said, for the same reason. It gives me almost endless options, and it also, as a result, gives me endless frustrations. But again, that's not my fault that the human body is this complex. When I first started teaching this information conceptually, I was actually very apologetic, because I knew people were coming to my courses and certifications going, hey, I want the answer. And they were hearing, well, there's 15 potential answers for this one question. And a lot of people got overwhelmed, and they were like, this isn't what I was looking for. And I'm like, I'm sorry, but that's not my problem.
Wow.
Right? If you're looking for, here's the 4 steps to fixing a migraine headache, I'm not your guy, because I don't think that's true. And I don't think it's ethical to tell people that. What I can say is, here's 17 different things that we can progressively work through and build a personalized approach for you that has a high chance of helping. And I'm also not afraid to say, none of this is helping. We need help, right? We need, maybe you need to be on a CGRP medication, or maybe you need some very specific prisms put into some glasses because none of the eye exercises we're doing are helping. That's okay. We don't have to be, none of us can have the expertise in every single field required to help people, but you do have to be smart enough to see it.
And also the humility to know that you maybe don't have the answer, because one of the things that you very eloquently described quite early on in the curriculum is that sometimes people will use the modalities that they're so used to. And then if the client doesn't get results, they almost put it on the client. They're like, oh, you've not been doing what you're supposed to be doing. And it's like, well, no.
That's what everyone
Like,
does.
yeah, we get so like in our own, like, what's the word? Like arrogant. It's arrogance, really.
And there's usually some truth on both sides. Like, you may have given them great stuff, and we know most people aren't great at doing their homework. But at the same time, if you're the coach and they're not doing what you asked them to do, yes, you can blame them.
Responsibility.
Or you can take on the idea of maybe they really suck at behavior modification. And
That was
maybe
my
we need to
favorite
spend more
lecture
time on
you
that.
ever did. You did this thing about, like, it's so funny because I was, just quick side note, I was watching the Z Health videos, and sometimes I get a bit in a panic that, oh, I haven't learned everything. So I was like, I skipped the behavior one. And then I realized that my strategy wasn't working. So I was decided to methodically go through every single video chronologically. And I got to the behavior one and I was like, you idiot for not watching this first, because it was so good. And yeah, anyway, that taught me a lot. I'm not going to go into that now because I think we haven't got a lot of time, and I really want to ask you about vision and vestibular, because these are huge, like, oh my goodness, now that I understand the neural hierarchy, we're all spending so much time in proprioception, and this is not a waste of time, but it's like at the bottom of the chain. Can you please talk about this? It doesn't have to be even relation to headaches. I just like hearing you talk.
Sure. So
more ranting.
Yes, more ranting.
Please.
The easiest way, I guess, to talk about this is, we have to make sure that people understand that as human beings, we're designed to move, I will say, elegantly through the environment, right? We should be able to be extremely adaptable, which means that I should be able to be here in my office, nice level floor, hear a sound outside that scares me, run down the stairs, run out, run into the grass, jump over whatever's out there, get to the dog, all without killing myself, right? If I only could rely on my proprioception to make that happen, it would be a big problem, right? You have to understand that we constantly use our visual system to know where we are in space, to navigate the environment. On top of that, we then have this kind of onboard balancing system called our vestibular system that does way more than balance, by the way, that is absolutely vital. And the smallest problem in the vestibular system can disrupt everything that we do. So as a movement practitioner, people have probably, you can watch other podcasts or whatever, but I had some early experiences when I was first in practice that blew my mind, where people had neck pain or whatever.
Mhm.
And I thought I was doing all this great stuff for them. And actually what fixed them was getting their lens prescription changed in their glasses. And I got super frustrated about that because I thought, hey, I spent all this time, all this money in school, I'm in practice, and I'm doing all this manual therapy and movement work with people and exercise rehab. And what they really needed was to fix their eyes. So that actually was kind of a big driver for what eventually is turned into Z Health, because it is impossible to divorce movement from visual and vestibular input. However, most of our educational models give very little thought to these systems because they are thought to be too specialized. So in other words, as a physician, you may be taught, well, if they've got an eye pointing out to the right, make a referral to the neurologist. But as a physician, you're not going to be taught to evaluate very much the quality of saccades, smooth pursuits, convergence, divergence, all these different eye movements, unless it looks like they've had a serious brain injury. The vestibular system is even more complex, and generally it's not even considered unless someone walks in and falls over. They're having dizziness, they're having vertigo,
Yeah, they
then
don't
they'll
even
be
look at it.
evaluated.
Yeah.
So if you want to be more full scope in everything that you do as a movement practitioner, these are systems that you have to have at least a basic understanding of. Even if you don't want to work with them, like if they intimidate the heck out of you, that's okay, but you still need to be able to test them and go, wow, look, when your eyes are open and you're trying to do this particular exercise, you have pain. If I ask you to close your eyes and you do that same movement and you don't have pain, maybe there's some information there that reducing visual input in this particular movement is decreasing your stress. What does that tell you? Well, that tells you that the eyes are probably playing a role in that pain presentation. And if you want to solve it, you may have to eventually look at their eyes. So that's a little rant about vision and vestibular in general. I believe that they should be cornerstone foundations of assessment and education for all movement professionals. I don't care if you're a DC, a PT, a DO, whatever, right? Just a coach, a trainer.
Preschooler, just
preschooler.
Everyone.
Yeah,
Let's just get it in there.
Yeah, it actually should be screened in schools. There's enough evidence showing up now with visual issues and vestibular issues, some relationship potentially to learning challenges that these should be screens that are performed everywhere. So anyway, I'm very passionate about it, not because I actually love having to teach people about this stuff, because it's actually complicated, but because the results I think are so profound that I don't think it's something that we, again, ethically can avoid. When you're talking about headaches specifically, I mean, everything when we just discussed, the visual system, the vestibular system, all that stuff's happening in the same spots that you're having the pain. And as we mentioned, when we talk about the brainstem, the top has to do with eye movements and also what's going on with your pupils and visual acuity. The middle part is involved in some eye movements and also processing vestibular input. So all these different things that we were talking about in terms of needing to address to change pain processes for people, you would expect then that the visual and vestibular systems are significantly involved, and they often are. In fact, there's a whole subcategory of migraine called vestibular migraine.
Okay, there you go. That's
so
enough.
It's recognized, but you need to know that it's there, so you can actually do some testing.
And people don't know how to test. That's what frustrates me. It's like they don't even ask you. Anyway, I mean, asking I think is one thing, but testing is a whole different thing, because I'll sometimes take history and I'll say, how's your balance? And yeah, pretty good. I can balance really well on one leg. And then I screen their vestibular system.
They're lying to you.
But they literally get such bad symptoms from the slightest head turn. Either they just want to lie down and go to sleep, or they're dizzy, or they feel like they're going to throw up. I'm like, this is not normal. Like, we need to look at this.
It's crazy. I'm always amazed at how good people are at compensating for deficits. Like, because once you really get into this, you'll meet people, you try and have them turn their head left and they want to throw up. And I'm like, how do you drive?
Yeah. It's crazy. How do they navigate life like feeling this unwell? Yeah, they literally turn their whole body. Especially, I mean, the client, she couldn't move her eyes, but when we tried to do the vestibular ocular reflex cancellation, where the eyes had to move together. She was really good at that side because she's always moving her head to get her eyes to that direction.
Absolutely.
It's just like, guys, please just, you don't know what I'm saying right now if you haven't studied with Z Health. So the only solution to this problem is to study with Z Health.
Believe it or not, I had a patient 20 plus years ago that drove I think if I remember, he drove 2 miles further every day to go to work. So he would only have to take right turns. Because if he tried to turn his car left, he would get sick So this is just like, people are adaptable. And I sometimes go, we're probably too adaptable for our own good. Like that's at some point, if you realize you can only turn your car to the right,
you need to let
you
that
may
look
want
down.
to speak to someone.
But the problem is these poor people do ask for help, and then they don't get the help that they need. This is what breaks my heart, and this is why I am really like telling people a lot about Z Health, because it helped me so much. Like you were talking about being evaluated in school for vestibular issues and how they could help your learning. I sucked at school, and I know I'm smart. That's what's so frustrating. And like now that I'm like doing my vestibular and my vision drills every day, and now I'm sitting down to study and I'm actually enjoying it, and I can focus and just like quality of life has gone up dramatically.
That's really, really great to hear. And, and it's something that we see with regularity. I think there is I think one danger that we run into talking about all this, like neurology is super cool. And there are times when you do 1 or 2 things for someone and it's literally life-changing. But I always try to emphasize the fact that that's not the anticipated outcome, right? It's awesome when it happens, but most of this is a progression. We are trying to change brain structures. We're trying to drive plasticity, and that occurs through practice and repetition. So normally when clients, or whatever, tell me, hey, thank you so much for all this stuff, my life's so much better, I usually go, I didn't do anything, right? I just went, try this, and then they did the work. So congratulations on doing the work. If you do the work, cool stuff happens. If you don't do the work, bad stuff happens.
Yeah, the thing is, we're always evolving, and the evolution is neither good nor bad. It just is, and we have to choose which direction the rudder is pointing. Which way is your ship pointing?
Yeah, and that's tied into this topic. It's interesting because what we'll actually see, and when we look at brain scans of people with chronic headache or chronic jaw issues, we actually see changes in brain structure over time. Wow. Like they're becoming better at having migraines. They're becoming better at having jaw issues. And that's why I think we are so dedicated to this idea of let's find things to drive changes in that pain signal. Let's try changes in movement, because ultimately we want to shift plasticity back into a more normal direction. I was looking at a cool study in preparation for this call on the jaw, and they did functional MRIs of people with chronic TMD, and found brain changes, and then they put them on splint therapy and exercise therapy, and then they reevaluated them. They're like, "Oh, cool, the brain changed." Yeah, I know, right? That's the cool thing about it. But it's have always to changing. Do it in the right way. Yeah.
Oh man, I could talk to you for a long time. We could have loads of rants, but there's no lights on in this room, and it's getting dark. So I think it's time to end the thing. Just before you go, though, can you tell us, if you had one message for the world, what would it be?
Oh Lord,
can be anything.
Yeah, I forget you always ask these kind of interesting questions.
sorry.
One message for the world. I think I'll stay on topic for now, in terms of what we do. If you have been struggling with a given issue for a long period of time, whatever that might be, the natural tendency of the human brain, when you don't make progress on something, is to quit, right? It's to give up. So, and as an example, if we're doing vision therapy with someone and we're trying to work on visual acuity, if I give them something that's so hard to read that it's super blurry, their brain will just turn off. It just goes, it's too hard, I won't do it. And I think that happens a lot when people are dealing with chronic pain issues, chronic movement issues, trying to change a behavior. At some point, it just seems so challenging that the brain says, you know what, I give up. My encouragement would be, don't do that. I've heard 1,000 times in my life, I've tried everything. I've seen everyone. And I'm like, well, nope, you've never seen me. Have you tried this? No. Have you tried this? No. So you haven't tried everything. You think you have because you're frustrated. If you find yourself frustrated and you feel like you've tried everything, the highest likelihood is that you probably haven't. So keep looking for people who have a broad scope a broad viewpoint on how these things work together, because there's probably some ideas out there that when put together well, might help you make progress in a positive direction. So that would be my encouragement.
It's funny because Mike, who I've interviewed also twice for the show, he said never give up hope, and I feel like that's the underlying message. Don't give up hope. There is answers out there for all of the struggles that we have. So thank you so much. Where can people find out more about Z Health? I mean, through me, obviously.
Through you,
I'll be
yeah.
your billboard. I'll be your billboard.
So our website is zhealtheducation.com. If you're a professional interested in kind of our approach, we have an 8-hour free online course and a free ebook called Neurofundamentals. If you're brand new to all this stuff, we have then our whole certification curriculum. We're Z Health Performance on Instagram. We're Z Health Performance on YouTube. So you can find us kind of all over the place. And we're pretty active on social media, despite my actual disdain for social media.
It's so hard.
But we're just trying to get information out there. So those are the easiest places to find us. And again, we try and make all this information available. If you are a client and you're not interested in professional training, on our website, we also have what's called Find a Trainer page. So if you're interested in finding a practitioner who could maybe help you look at some of the issues that you're having, absolutely go there. You can put in your location and find people close. As well as a lot of our trainers now also do online work. So there's a lot of possibilities out there.
Yeah, there's so many. Thank you so much for your time, Dr. Cobb. You're a legend.
Absolutely. You're very sweet. It's good to see you.
You too.